For years, CHOP or something like CHOP has been our standard therapy, and that does okay for some people. Clearly lots of room for improvement. So we have this wave of studies going on, which are new drug X that got approved, looks good, adding it to CHOP. And I think those studies some are almost done, others will be done in a year or two, and I think that's going to tell us a couple of things. One, does something in addition to CHOP make it better? And is CHOP a reasonable backbone? And if it does make it better, does it make it better overall or for certain subtypes? And I think what's going to happen then is we'll have a group that is CHOP plus X or something like that maybe makes sense. And then we'll be left with a whole bunch of other subtypes where probably CHOP's not the right strategy. So trying to incorporate into clinical trials our understanding of which patients respond, predictive biomarkers, looking at if we inhibit something in the JAK-STAT pathway, certain patients respond, others progress. Why do they progress? How do we wrap in those better combinations? And getting into a more targeted, individualized approach. So I think that's one of the main things that's going to take time. But my suspicion is for such a heterogeneous disease, we're going to have to understand that to really get better therapies. And then also the use of immunotherapy. So because these are T-cell cancers, our experience and confidence in giving things like immune checkpoint inhibitors or T-cell therapies has been a little bit behind other cancers because of the concern that some of the cells you're stimulating, may be the tumor cells. So we're just starting to get some data at that and trying to understand, is that strategy, which is so effective in other diseases, going to be effective here? And if so, in what ways and in whom? And I think probably the next, some number of years, those are going to be the things we'll learn.